I'm having trouble with my my background, so can you hear me okay?
Yeah.
Yes.
Okay. I will sort this out in a second. So, welcome to the Evidence-Based Guideline Subcommittee meeting on April 10th, 2025. We're looking forward to the conversation we all are going to have today and want to make sure that we are all dialed in for conversation. Large part of what we're going to do today is talk about our benefits update work. And so looking forward to that. And I think, Jason, I hand it over to you to talk about where we head next, right?
Yeah. Orientation presentation.
Do we want to do the roll call first or do after
We'll
the
do that
orientation?
after.
Okay,
We might have a couple folks trickled in.
sure.
All right. So just to orient everybody again, this is the Evidence-Based Guidelines Subcommittee of the Health Evidence Review Commission. As a reminder, the Oregon Health Authority has set a goal to eliminate health inequities by 2030. Our purpose here today is to develop reports to guide coverage for the Oregon Health Plan and other plans. That's the main typical purpose of this group, but in addition to that, we'll be doing some work um, related to our benefit updates project, which is preparation for the end of Oregon's 1115 Medicaid waiver. So it'll be a little bit more rapid review of higher quantity, less depth on many more topics in different specialty areas. In both cases, the decision will affect over 1 million OHP members, as well as their families, caregivers, and providers. There won't be any decisions about individual care made here today. These are all policy level discussions. Again, EBGS's main role is to develop coverage guidances and like we will review today, and multi-sector intervention reports, which we will not review today, to guide coverage of health services by health plans, including the Oregon Health Plan. Sometimes commercial plans look at our work as well. We will also advise HERC on medical necessity for the benefit update project. Reports, none of these decisions are final until they're approved by HERC, and they will be implemented at later dates. Most of the materials reviewed today will go either to the May or June, May 15th or June 12th Health Evidence Review Commission meetings. A little bit of TBD there, depending on other things that are going on, but one of those two meetings. And for anybody who doesn't have that June 12th HERC meeting on their agenda, calendar and wants to attend that, that is 1:30 to 4:30 p.m. We just scheduled that a couple of weeks ago, so making everybody aware. As we do this review, major considerations include, but are not limited to, the following: what outcomes are important to patients? The assessment of the harms and benefits of any given service and what the balance of that is, patient values and preferences, stewardship of public resources, and the nature of the healthcare delivery system. We want to make policies that can be implemented. For logistics, for members, as much as you're able, please be on camera and attentive. If you can't, please actually message Jessica if you're stepping away or departing. Daphne is not able to be here today. And Jessica or myself with logistical issues. Votes will be by roll call. This is a new requirement this year. If you missed the last meeting, that Jessica will be calling the roll, and you can just respond A or nay or abstain if you need to abstain for some reason. For those, we don't have any verbal testimony today, so we'll skip that section. Anyone else who's observing, if you're having trouble hearing or having some technical difficulties, again, use that Q&A feature in your Zoom settings, and one of us will respond to that as we are able. We can't address a lot of complex questions that way, but if there's a simple logistical question, we'll do our best to do that. The chat and the question and answer for the public are part of the public record and could be revealed in a public records request. This meeting is recorded and will be posted online. If you have more substantive comments any day of the year, please use that email address, herc.info@oha.oregon.gov, and we will do our best to address your questions or concerns.
Thank you, Jason. I think we need to go on to the roll call now.
Yes.
And is Jessica going to take it?
Yeah, Jessica. if you
Can.
go.
All
Thank you.
right. So Mimi McDonald,
Here.
Mark Buckles,
Here.
Deb Espacente,
Here, present.
Devin Kinsagara,
Don't see Devin.
okay. Abigail Khan will be absent. Larry Lyon, Dr. Lyon.
Oh, did you hear me?
Yeah, we
Nope.
can hear you now.
Oh,
Okay.
yes or no?
Yes.
Yes.
Oh, let me move my microphone closer to me. Okay. All right.
Kat Livingston,
Present.
Leslie Sutton,
Leslie will be here a little later. She's had a conflict.
and Linnea Lindsay.
Here.
Excellent.
Is that a quorum?
That is a quorum.
I believe so. And just FYI for folks who are attending, feel free to use the Q&A function if you would like to ask a question.
Thanks, Jessica. I think we now need to move on to the approval of minutes. The minutes were from our previous meeting are in your packet. So we need someone to move the approval of those minutes.
I make a motion that we approve the minutes. This is
Second.
Mimi McDonald.
Thank
Larry,
you.
second.
Thank you, Larry. So we have, any questions or concerns? Let's move on to a vote. And again, we need to take a verbal vote. So I think we do it by roll call again. So Jessica, will you take us through that?
All right. Mimi McDonald,
Approve.
Mark Buckles,
Approve.
Deb Espacente,
Approve.
Devin Kinsagara. Absent still?
Absent.
Okay. Abigail's absent. Larry Lyon,
Approve.
Kat Livingston.
Approve.
Leslie still hasn't arrived yet, so that leaves Linnea Lindsay.
Approve. Thank you.
Motion passes.
Okay, thank you. So I think then we're on to staff report.
Actually, before we do that, if we could do a conflict of interest. If anybody has a conflict of interest or potential conflict of interest or personal interest to declare, please do so now. Hearing none, I will go on with my staff report. So the retreat is coming up next Friday, April 18th, 8:30 a.m. For social time, and then we'll start with introductions and icebreakers and so forth at 9, and we'll go until 4 p.m. in person at the Portland State Office Building near the Convention Center in Portland. If any members need help with travel or logistics or directions or whatever, please let us know, or members of the public if you want directions. There will be an option to attend online as well, and look forward to seeing many of you there. Next, I have some really great news to report. Today, we have joining us Dr. Heidi Gollett from Ohio, who is our new medical director, along with Ariel Smith. She's joining us half-time. Some of you may know her. She's been in Oregon before. Heidi, would you like to take a moment to introduce yourself?
Sure, thanks so much, Jason. Yeah, I did my residency training at OHSU along with several of the folks here in family medicine and public health preventive medicine, and have spent most of the last couple decades working as a family physician in federally qualified community health centers, and also working as local public health medical director. So really grateful to be here with you all, and looking forward to working with you. So thank you so much, Jason.
So awesome to see you, Heidi. So everyone knows she was my third year and year in residency.
Really great to get to see you again and work with you all. So thank you, Ariel, for letting alumni know about these opportunities.
Oh, Jessica, I'm getting a message from Devin that he's attending but hasn't been promoted. Could you promote him?
I just did.
Oh, wonderful. Welcome, Devin. So the record show that Devin
Oh yeah,
is
now I
already
think it
with us.
works.
Great to have you here. So, Devin, I just had Dr. Heidi Gullett introduce herself. She is our new medical director, along with Ariel. Just started April 1st, so we're excited to have her join us.
Awesome. Nice to meet you.
Nice to meet you too. Thank you.
All right, a couple other updates. Legislative updates. So there are several bills that are related to our work. There are several bills that we would mandate coverage of services that are not currently covered. There's one on biomarkers, which is a very broad array of medical tests on human tissue. There's another one on continuous glucose monitors, which this group reviewed not too long ago. And there is another one on coronary artery calcium scoring, which was reviewed by the HERC recently. And all three of these bills would expand coverage. They have passed out of the health committees to which they were assigned, and they will have a fiscal impact. So they'll also need, they passed out of the first chamber. They would have to go to the second chamber, pass out of that chamber. Then they would be referred to Ways and Means because they have a fiscal impact because they're costly services. We still don't know what happened. There can be amendments, bills can die, but those three bills are moving forward. In addition, there was a bill related to the Benefit Update Project, House Bill 2917. OHA withdrew that bill, determined that was best. So that will not be moving forward this session. There is another bill that will form a task force on related to the end of our waiver that we've been talking about with the Benefit Update Project. Nonetheless, either way, the waiver ends, and we're going to continue doing our work. These decisions, will need to be made. There may be some changes we have to adjust as we go forward, but for now, we're just continuing according to our original plan. Any questions about legislation before I go on? All right. Also, Judy Richardson, a member of the subcommittee, had to resign. So we are down to 9 members, which is completely fine. We do have, however, an open recruitment we could add up to 2 more members to this group. So if anyone listening knows a good person who would be a good candidate, please ask them to reach out. In addition, we will have a vacancy at the Health Evidence Review Commission. This is the governor-appointed parent body for a consumer representative that will be open at the end of May. Leslie Sutton has been filling that role, but she'll be a term limit. So if you know somebody who would be a great consumer representative, we'd really like to be put in touch with that person. Yeah, and I think that is all for the staff report.
Excellent. Thanks so much. I think next we have the review of the public comments for coverage guidance, the surgical treatments of obstructive sleep apnea. Who's taking us through those?
Courtney,
Page
do you want
117, I believe.
Courtney, do you want and Shauna, do you want me to run through them or are you all planning to?
I believe it is you, Ariel, but
All right,
would
happy
be-
to.
Oh,
We
we should
received-
introduce Dr. Lamb.
And Dr. Libby, they're both here.
They're both here. Okay, let me give their bios here. So welcome, Dr. Lamb. Dr. Lamb, Derek Lamb, is Associate Professor of Otolaryngology at OHSU. He's the Surgical Director of the Dornbecker Aerodigestive Clinic, where he manages complex aerodigestive disorders in children. Additionally, he's the Surgical Director of the Upper Airway Stimulation Program focused on nerve stimulation to address adult obstructive sleep apnea. He conducts NHLBI-funded research focused on the diagnosis and surgical management of pediatric obstructive sleep apnea. He has no conflict of interest that meets HERC's disclosure threshold of $200. Dr. Louis Libby is a retired sleep medicine specialist practicing from 1985 to 2021 with the Providence Health System and the Oregon Clinic. He's board certified in sleep medicine, pulmonary medicine, and critical care management. During his practice, he treated many patients with obstructive sleep apnea, and he has no conflicts to disclose. So welcome, Dr. Libby and Dr. Lamb. So glad to have you here, and they'll be here to answer any questions that might arise in the discussion. That, Ariel, take it away.
Yeah, so we only received one public comment on our coverage guidance for surgical treatment of obstructive sleep apnea. This came from one of our colleagues who is one of the pharmacists who assists with the Pharmacy and Therapeutics Committee for open card fee-for-service Medicaid. And her concern was mainly around tirzepatide, which is it's also known by the brand name Zepbound. It's one of the GLP-1 inhibitors that can be used for weight loss, but it also was recently received approval by the FDA for treatment of sleep apnea. We had in our suggested sort of coverage wording that someone needs to have tried and not responded to CPAP and other conservative therapy, and she just wanted to clarify whether the conservative therapy included medications like tirzepatide. And she gave us their current drug review and other resources from PNT. So in response to her comment, staff put in a couple of extra words to what you all saw at the last meeting. So rather than it had said inadequate response to CPAP or cannot tolerate CPAP or other, I believe it said conservative treatment. We are modifying that to other appropriate non-invasive, non-pharmacologic treatment to clarify that we are not going to require someone take a medication like tirzepatide prior to being able to access the surgery. And then the same or very similar wording will be under the second section for tonsillectomy with the just mainly clarifying that, again, we aren't going to require pharmacologic treatment. The patient may be appropriate to treat with medications, and that would be a conversation they would have with their treatment team about whether they should try that prior to surgery, but we are not going to require it. Any questions, concerns? Are you all comfortable with that slight change in wording?
Yeah, I think that's helpful. I think it sort of intimates that sort of like oral appliances or things like that should be tried, but excluding the medication. So I actually think that's very helpful.
And it aligns with our conversations.
Yeah, and we're not excluding the medications from possibly being considered. We're just saying that you don't have to have it before you would be eligible for surgery.
I agree.
I'm comfortable with that.
Yeah. Do we need to do anything to reach a consensus on that or vote on that, or do we just?
Yeah, so the next step, just because we don't do this very often, the next step would be for this. So this subcommittee already voted last meeting to put it out for public comment. And then now we have the public comment, some staff recommended changes, which everybody appears to be okay with. The next step would be to vote to refer it to the Health Evidence Review Commission for their review, either in May or June.
I motion that we do that.
Thank you, Larry. Do we have a second?
I will second that. This is Mimi.
Thank you, Mimi. So now we'll go to a roll call vote about moving the surgical treatments for obstructive sleep apnea coverage guidance as modified to the HERC full committee. So Jessica, take it away.
Mimi McDonald.
Yes.
Mark Buckles.
Approved.
Deb Espacente.
Approve.
Devin Consagara.
Approve.
Okay. Larry Lyon.
I approve.
Kat Livingston.
Approve.
Leslie Sutton, are you here? I'm going to take that as a no. Linnea Lindsay.
Approve.
Motion passes.
Thank you. So I think that's all we had for public comments. And I think we're a little bit early, thankfully, in moving into the benefit project update. Is that correct?
And Dr.
That is
Lamb
right.
and Dr. Lamb and Dr. Libby, this will go to the HERC. I anticipate it will come to our June 12th meeting because our May agenda is already very full, um, and staff will reach out to you offline to give you all the information so that we would really like it if you could attend the meeting and answer questions.
Thank you so much for your help developing the report.
We are on page 121.
Didn't we have an opening slide set, Jason?
That's right. We did have an opening slide set. Let me find that. Since this work is a little bit different, Liz, it's in the 41025 folder up above the minutes. If you could bring that up. Just because this is a little different, and I know it was a little bit disorienting for the committee last time, as would be expected. Ariel prepared these slides to kind of help talk about what our task is for these BUP.
Yeah, this is mainly to reorient you all because this is a different type of review and type of decision making than you normally do with coverage guidances and multi-sector intervention. So I just wanted to quickly kind of run through a few slides and touch base with you all. Next slide. So just as a quick update, the BUP, as we would affectionately call the Benefit Updates Project, because we have to have acronyms, we're state government. It does not change decision-making standards, but it looks a little bit different. HERC policy will no longer be shown in the prioritized list as you're traditionally used to seeing it. It will be more code pairing files, coverage guidelines, and statements of intent. There are program rules that are in Oregon Administrative Rule or OAR that'll continue to apply, but we'll no longer have a funding line. And you can kind of think of this as a flat prioritized list. So, all things have the same prioritization essentially. Next slide. So this is just kind of a graphic to show you on the left is sort of our current state, and you've got the unfunded region in green. That's really going to move over, and our big decision is going to be whether what's in the unfunded region needs any particular service other than sort of office evaluation, in which case we'll add that to that yellow newly covered service. If we decide that nothing other than office visits, et cetera, is really necessary to treat it, it will end up those other like surgical services, et cetera, will be not medically necessary. And then we're always going to continue to have a small green box. These are non-covered services. They're in our state plan. They would include things, for example, like infertility services that we know actually are effective, but we are restrained from covering them because of federal and state rules. Next slide. So this looks like a prioritized list line and guideline, and I put this in here to kind of show you that things aren't changing a huge amount. Instead of line whatever, it will be code group whatever, and then sorry, yeah, perfect. And then we'll have coverage guidelines instead of guideline notes, and things will be medically necessary instead of online whatever. So there's a lot of just technical changes, and what you're seeing in front of you is not set in stone. This is our kind of working draft of what we're doing, but we think it'll land being something similar to this. Next slide. So this is a different kind of review. What you all are really used to is seeing a very in-depth review that the Center for Evidence-Based Policy and their staff does a great job. They present all of the information to you, and you can have a really in-depth discussion and use experts. This is kind of pivoting to a really superficial look. So staff has prepared this. There's in many cases not much in-depth evidence review, although we have consulted experts. So your job today is really to look at what conditions or what procedures or what things are being shown that you just want more information on. Or you have a question about, is that really something that we want to cover for this condition? Is it really efficacious? Et cetera. Those are the things I just want you to call out. And then looking at guidelines and calling out things there. Next slide. So this is an example of the tables. I'm sure if you had a chance to look through all the meeting materials, you saw a lot of these at the ends of each of the summaries. And this is sort of, if you look on this, allergic rhinitis, for example, which is that third sort of line across, was proposed for allergy testing and treatment. When this was shown to the HERC back in November, staff were requested to do an evidence review to find out if it really is effective and cost effective to do allergy testing and treatment for allergic rhinitis. So the commission called out that diagnosis and that treatment and asked for a further evidence review. Next slide. So you have options. You can look everything over. It makes sense to you. You agree. You can just approve as presented. You can request an evidence review, like I showed you that example. You can request additional information. We reviewed topics at our last VBS meeting, and there was concern. People were like, this is a really rare condition. I'm not sure what it is. Can you get me more information on it? You can request expert input. So I've worked with experts in each field, but a lot of things have, like we talked about ophthalmology issues at our last VBS meeting, and there were a couple where people were not comfortable with the proposals, and they really they had some very specific technical questions for the experts, and then some more large picture questions. Next slide. So I put this up here. At our last EBGS meeting, you all looked at the gynecology topic and approved it, and it went to HERC. And I just wanted to give you feedback on what HERC said. You all did a great job. Nothing that you did was wrong. HERC just had a lot of questions, and you'll see this again in the future. I wanted to put this in here so you can see kind of the types of questions that HERC was bringing up that are things that would be totally within your purview to ask our staff as well. So they wanted an evidence review for the effectiveness of hysterectomy for both dysmenorrhea and chronic pelvic pain. They wanted more information from experts about a possible guideline for when benign vulvar lesions should be removed. They wanted information on the evidence of when post-endometrial ablation syndrome needs treatment and what types of treatment. They wanted additional information on Bartholin gland cysts, mostly around the different types of diagnoses. So if it was an infected cyst, it's covered. They wanted more specifics there. There was one other specified condition type of codes. They wanted to know what subdiagnoses were there and to see what might be needed to treat them. And then they wanted questions about what a trachealorrhapy really is and when it's clinically indicated, when is hysteroplasty for uterine anomaly is indicated, and when does a uterine septum need to be resected or divided? So these are all questions that you'll see again. I'm working with our gynecology folks to try to get answers to these questions, and you'll see that when we've gotten more information, we'll bring it back to you. But I wanted to put this up as just an example for things that you all are welcome to do. Yeah, any questions? Hearing none, do you want to just jump in?
If I could just amplify a little bit what Ariel's saying, we are flying fast here, and we are doing that not because we are hoping you to just nod your head and rubber stamp, but because we fully expect that some things got missed. We want to focus on the right things that you believe are important, and so please don't be shy.
Yeah, and our
want to get this right.
timeline, our timeline is we're showing this to you. If, like I said, you could just approve it if it all makes sense. If you want more information, it will come back to the next meeting. We need a decision from this group probably by the fall on any of these topics. So it's not something that we have to decide today. But we do need to review them and get your input. Okay. So the first benefit update project topic that we have is dermatology. And what I have done for dermatology is there is sort of a global topic with things that really didn't need a lot of changes or a lot of input. And then there were several topics that have either in the past elicited a lot of interest or discussion, or CMS is very interested in, like actinic keratoses, that I broke out and did a more in-depth review. So there's some things, some topics that you'll see kind of broken out. And then there's sort of the general one. So the first sort of general thing, which includes most of the dermatology diagnoses and treatments that are below the line, that was in your packet. It went out for public comment. Pharmacy and therapeutics folks had some concerns with the staff recommendation to include Botox injections for pulmonary hyperhidrosis because it's not FDA approved and doesn't really have a lot of effectiveness in that area. And they provided their evidence review. And the staff recommendation was changed so that Botox will only be for axillary hyperhidrosis. Just of note, we had a staff listening session. So HERC staff are having quarterly sessions where providers, patients, and others can just come and talk to us about issues that they're having. And at our one last week, we had a general surgeon from rural Oregon who had a lot of questions and concerns about the proposals about lipomas and cysts that and she requested that we do more look at that area. So that's already one area that we know will probably need a little bit more in-depth discussion. So these summaries are also a little different, like you saw with gynecology. We kind of start with like the key messages right up front. And it kind of starts with the things that I think might need more discussion, and then kind of just goes down to those things that are just technical changes with no real coverage change from current. So the things that you might want to talk about or have an interest in is adding coverage similar to acne for pseudofolliculitis barbae, which is a condition of the sort of beard area that's like acne. For hyperhidrosis, it currently pairs with chemodenervation of the axilla, and that will move into more formalized coverage. It also is paired with pulmonary hyperhidrosis, and as I mentioned earlier, we're going to not pair that anymore. And then, according to our experts, granuloma annulare needs phototherapy, steroid injections, and laser therapy, so it will be paired with those. And then pyogenic granulomas will have some new treatment. And then there's some new diagnoses that will have some dermatology procedures. Again, this includes skin cysts, which I'm going to probably need to do a little bit more work on based on our surgical input, as well as lipomas. Experts wanted coverage for wigs. We have had issues in the past with coverage of wigs for non-cancer related care, and staff is continuing to acknowledge that this is an issue, but also acknowledge difficulties with covering it and continue to recommend non-coverage. And then similarly, hirsutism and other hair conditions, we are because of a different rule, we are very limited in what we can pay for things that are considered to be primarily for the intent to improve appearances. So despite expert recommendation.
Mimi has her hand up.
Sorry, Mimi, go on.
Sorry about that. No, I just wondered, like, as you're going through this, do you want us to stop, or are you going to do a summary of all things derm and then come back for questions, or
Yeah, I was just going to do kind of a summary of the topics, do a little bit more detail, and then we're going to open it up for
go by
any.
Okay.
Yeah, unless anyone wants to, already is really, maybe just jot a note or something if you see something already that you're concerned about.
Okay, sorry.
Yeah. And then there were a couple of rare conditions that experts wanted us to add treatment for. They're very, very rare and may or may not require treatment. So we thought that the exceptions process would still be appropriate for those. Most dermatology conditions are going to continue to just be in what we're calling the evaluation and medical management group, which would allow office visits, diagnostic tests, patient education, medications according to their FDA indications, and possibly with step therapy, et cetera, et cetera. That's similar to what we believe current coverage is. And the experts who worked on this were Doctors Greeling, Schwarzenberger, Doshi, and Fett from OHSU Dermatology, and we are very thankful that they took the time to help. So what staff are proposing is to create a new code group called Dermatology Conditions Requiring Procedures. The procedures would be things like chemodenervation with our current guideline limiting it to the indications that we currently call out, intralesional injections of steroids and other medications, excision, and laser therapy. And this would include some currently covered lines. So our hemangioma, port wine stain, acne, hidradenitis suppurativa, a lot of the inflammatory skin disease lines and cystic acne would all be put into this group. And they're all currently paired with these procedures, and those are covered lines. So they would be moved into this group, and then we're going to add currently uncovered diagnoses. So these are all the guideline notes. I thought maybe what we would do for the first part of this is actually go down to the code tables. And then once we've kind of figured out what else we might want review on, then we can come back to the guidelines. I just want to call out that there is a new skin guideline that's being written as part of this, and the rest are mostly just modifications. So every topic and every topic summary has this very large table in it. And I don't know what your preferences are. We could kind of slowly page through them. If you already know a few things that you want to call out, go ahead and call those out. If you have questions, you just want some more information, call that out as well.
So I'll jump in there just about one of them as I was looking through it, and this is regarding coverage of treatment of scar tissue. And so the two specific ones are L90.5, which I think I can't remember. It was already on the list, and L91, which was also on the list too. My question about those guys, sorry, make everyone scroll like maniacs to go to the bottom, has to do with the specifics around pairing. So not even necessarily the specificity of when someone, so if a guideline note does say something like, yes, it must cause some either physical impairment or pain, which can be a little bit vague. Mostly, I mean, honestly, I was thinking a lot about keloids and the treatment, and there's so many treatment options. And I'm wondering if there will be kind of a look into that and some sort of guideline note about what is acceptable or what is best. Because I think that in that arena, there's a wide variety of what people might do.
Isn't that line L92.9?
I saw, so you've got L90.6 to 9, or no, I'm sorry, L90.5 scar conditions.
Yes, and then L91 hypertrophic scar.
Okay.
And then there's also L92.9, which the current says current line 596, keloid scar.
L92.9. So L91.0 is hypertrophic scar. L90.5 is scar conditions and fibrosis.
I thought keloids fell under L91.9 or L91.
L91.9.
Yeah,
I can
or
just
just
highlight it.
L91, sorry. Just the hypertrophic scar. I think that's where keloids usually fall.
Okay. What I can do is, yeah, so I think the proposed guideline was just they had to have pain or functional issues.
Right. Just,
I
feel
but
like those,
we
yeah, those are
we
pretty
can
broad, and could be broadly interpreted. But then also, again, like I said, I think the main thing is, I think pairing appropriate therapy, or recommended therapy, I think would be really important.
I see Mark Buckles has his hand up.
Yeah, I would also like to comment just on that word pain. I would recommend removing pain and just limiting it to functional impairments because for EPSDT, we already look at pain for under 21, and pain is so subjective, and we see so many of these that are 100% cosmetic but could be subjectively pain that it will effectively cover all scars and keloids.
Okay.
If I could
Okay.
just go back, Larry had highlighted L92.9, and that one is proposed for evaluation and management only. And so were you asking us to look at whether there should be some procedures for that one? That's granulomatous disorder of the skin and subcutaneous tissue.
I was a little confused because in the middle section it says keloid. So I'm just wondering, is that included in the lower sections, the 90?
I will make sure I figure out which codes are used for keloids.
Okay.
So I'm hearing concern about scars, keloids. What treatment what treatments do they actually need and when do they actually need to be treated, considering removing pain?
And to Mark's point, is psychic pain included in the evaluation of pain or the definition of pain?
That's a metaphysical question. Um,
Certainly someone who has a keloid or some disfiguring scar, that can, I mean, that can be concerning to them. Is that something that would be covered? And if so, what would be the evaluation standards for that?
Actually, I think even within, just as I was reading through the dermatology stuff today, I think there's somewhere in a guideline note that sort of specifically says, related to, I don't know if it says emotional issues, but I think it might around, skin
so
conditions.
The following diagnosis
oh,
only
that's our
require.
general, like the inflammatory skin disease guideline. There is a dermatology quality of life index
Huh?
that we've used. So we actually, and that's functional impairment as defined by, I could look at that and ask the experts if that would be a valid instrument for scars. I think it's mainly used for like eczema, psoriasis, that kind of thing. But if it is applicable, that might be a good thing to use.
If there's some type of validated scoring mechanism for someone, for instance, who has a disfiguring scar, so that there is a standard that can be followed, that could be very helpful.
And then one of my other questions, Ariel, and sorry, because I don't know the answer to this one, is, does this include, burn scars, or is that a completely separate?
A burn is completely separate.
Okay.
But the sequelae,
Yeah,
I
the
mean, we've
sequelae of
always
burns.
covered like, the eschorotomies and the other, those. I will look that up and I will make sure that we're not doing any limits on like the major burn
Right.
things we
Okay,
already
great.
cover.
Thanks.
In addition to a dermatologist, it may be helpful to consult a plastic surgeon.
Yeah.
And regarding this issue of appearances, because it's going to come up, there, as somebody said, there is a administrative rule that says services principally for the purpose of improving appearance are not covered. That said, HERC has covered some things for reasons related to social function when it's very disfiguring, and it's a judgment call. And my understanding is that from a legal perspective, it is HERC's call where to draw that line. And so that's what we're looking for input from you all. If you believe something is principally for appearance, you can put it on that evaluation and management line. If you believe it's sufficiently, it actually causing a social function limitation or someone said psychic pain, however you want to interpret that, that's exactly what we're here to do.
So, Jason, does that mean that we are creating guideline notes that then say medically necessarily, that because we're looking at medical necessity, are we having statements of exclusion? And because I think I'm trying to sort out in my head, where's the clinical decision making? Where's the line around that? And what language is really the best? So I appreciate Ariel going to folks who practice in this area and seeing what their take is on this.
Yeah, I think the idea is to write a policy that can be clear enough to be applied and not, so wide open that we're wasting resources. But there is always an individual review and exception process, especially for children. But there's an appeals process for an adults and where exceptions could be made. But we want to get the best policy we can to guide, to give direction to that. And so like on the inflammatory skin disease line, I think it references, things on the hands, feet, or face. There's also a dermatological quality of life index. Those are some of the kinds of things that you could use to give a little more objectivity to it. If you leave it wide open, it'll be the judgment of the medical directors applying that rule that says principally for the purposes of improving appearance.
Yeah, I'm trying to think how you limit it if there are body folds or places where it may be interfering with, you can talk about function, but somebody else might consider it cosmetic. I think there's some challenges. Derm is just one of those challenging pieces. So I'm just curious what others think about that.
Good to consult also. Not just the appearance of the skin, but also in terms of function.
I would be curious to know from the medical director's standpoint if this notion of leaving it as functional limitation, based on your past experience, if you think that would be misused or misinterpreted by practicing clinicians. I think this idea of limiting stuff for cosmetic reasons is pretty well enculturated. I think most major insurers, and the VA is the same, approach things in that way. So I'm just curious where you think the specificity needs to be based on what you're hearing from, folks' requests for.
I've retired from my position as medical director, and I do have a new job. But what I would
Yeah.
say, Devin, is that the options which can be challenging is either to provide oversight, let's just say we'll just use like scar excisions, all right, could potentially require a prior authorization, right, which is another, a rate limiting step certainly and requires resources and all those things. And so that's one option. The other option is that's if there's sort of no guideline notes or anything attached to it, or if they're very vague, where almost you can do a prior authorization, you're almost 100% sure that you're getting it. Unfortunately, that there are sometimes, certainly understandably, if a person is in front of you, a patient's in front of you and says, "This is bothering me, please take it off," it is there. I do think there needs to be some type of oversight, and that's kind of why I was requesting the more specific things around keloid treatment. And the other option is to not have a prior authorization, which everyone likes more, but then there needs to be again some oversight, because sometimes there are some providers who may not be as concerned about the overall fiduciary responsibility that we have for the members who are of the state of Oregon and taxpayers. So it's kind of like you get one or other of the sides you need to sort of pay attention to.
Thanks.
And I would agree. I guess my concern was back to the pain is the consistency among different diagnoses that we see. That pain is often used with many other diagnoses that aren't covered, and it's not a common coverable term for OHP. Just the word by itself, pain. Normally, there's some sort of functional limitation or some sort of objective criteria that we can use and be consistent among reviewers, appeals, as well as if it goes to hearings. Everybody is on the same page.
So I'm hearing a lot of concern with the new proposed guideline and coverage for a variety of skin conditions. You've all brought up scars and keloids. The surgeon that spoke last week talked about skin cysts and lipomas. Do you all have any concerns with foreign body granulomas or calcinosis cutis? Do you want me to look into those as well? Those are the last three on here.
I don't think those are things that would be overutilized or.
Okay, that's good to know. I will make a note. Green. I'm sorry, I'm highlighting it.
Well, it's interesting. It can cause joint stiffness and limited mobility. So, in terms of calcinosis cutis, there's the condition, and just as Mark said, the function is the thing that I think a lot of people, I think is a very good thing to focus on.
Yeah, and for other skin conditions, we've used this dermatology quality of life, which probably does include pain. Would that be something that, if I talk to the experts, would that be something you'd be comfortable having a scoring on that? Or do you think I don't even know if it's useful. I don't know if it's cross.
I don't know. If there is, I wonder if there is some type of validated scale that currently exists.
Yeah, that's what that quality of life scale would be. But there may be another scale. Yeah.
Yeah. And then the condition itself is one thing, but then if there is some type of functional problem as a result of the condition, that's an additional that's a burden.
Okay, so I have flagged all of those types of things that we had called out in that guideline. The majority of the other conditions are either just going to be evaluation or management. Some are actually going to end up being in the allergy group, as because they're allergic dermatitis and things like that. There are some things that are proposed for being in what we're calling the not medically necessary file. Those would be things that um, we would not want to cover, because uh, uh, so we're still working out some buckets. Not medically necessary would mean that somebody could appeal and have sort of like ask for an exception. If it's excluded, it's outside of the benefit package. It can't even be in um, a value. You couldn't request anything. It's just not covered. So, for example, most things about hair loss we are not allowed to cover because of CMS rules. Um,
Yeah, and I think what we talked about is for most of these issues that would be appearance, because they're, you know, people are different, they're different circumstances, different parts of the body, that these kinds of things would be either medically necessary or not medically necessary. There is that blanket rule that says if it's principally for appearance, that also exists and could be used as a reason for a denial, but that we wouldn't want to put these out of the benefit package entirely, because then that if there'd be new evidence or if something would change, it would be a much heavier lift to change that policy in the future.
Is it so with the evaluation and medical management, that would be including the functional, I keep trying to move the screen here, sorry. The functional, so that would be pain or functionally limiting
No.
and I
The evaluation management group is just, you get to see a doctor, the doctor looks at it, makes sure it's not cancer or not something else, decides what it is, and no procedures are covered.
Okay. But if something were, so I'm wondering about the question here too, is that some of these things are not considered not medically necessary, can have a large effect on someone's social and interactions and their in participation in community, which might be captured by quality of life measurements. So are you
Right.
saying that if we
So if that sort of thing would rise to the level where you'd want it to be eligible for a procedure, it should not be on the evaluation and management group, but it should be on the dermatology conditions requiring procedures.
Yeah, and like alopecia areata has been a bone of contention for years. It's an autoimmune disease where you lose all your hair, but we actually are tied by CMS rules. We can't cover it, so it would have to be excluded, or at
How about
least not.
the lichen planopilaris has often the lichen are very visible plaques on the skin. Sorry, excuse me for that's not the accurate medical term. There might be like a visible but I don't know. It would be really interesting to know from experts, yeah, if any of these can have a range of severity that could be at their worst flared up, if that's the right word too, could be affecting quality of life. So I don't know if that's what also is being said, if there's so it sounds like if something is not medically necessary, that's period. That's the end.
No, so excluded is the end. So there are some things that we can't even consider paying for. They're out of the benefit package and they might be effective. For example, we have very effective treatments for alopecia areata that are medications, but we can't pay for them because of federal rules. If we say it's not medically necessary, there would be and something that's excluded might have good evidence that it works. It might have good evidence that it's needed, but we just cannot cover it for whatever reason. So there's no appeal. If it's not medically necessary, that's a little bit softer. And that is, we don't, it would be sort of how we're kind of looking at the prioritizes right now with some things that are non-funded. You have appeal right. You can still ask and make a good case. You know, my patient has the following problems related to this condition. And then, if it's convincing, a medical director could say, yes, I agree with you, versus like alopecia, where everybody agrees that there's medications that work, but we can't cover them. So
one way to do this, I think would be helpful from you all, is like I heard some real reservations about including pain, just the word pain as a criterion. I heard positive things about requiring functional limitation. I haven't heard what about social function, should that be considered? And it'd be interesting to hear what the group thinks. Would you like us to bring back options that encompass that? Would you like to explore the dermatology quality of life index? Like, I don't think we're going to hash this out today, but it would be helpful to have some guidance on what direction.
I'm thinking that, to your point, Jason, I think that when we talk, I mean, if we're going to talk about health equity, okay, social function is part of health equity because that has to do with opportunity. So I think that we're not going to find a one size fits all. I think it's really appropriate to get expert opinions from derm and plastics, see what scales are out there if they are validated and how they could be used. But also because of the variation and because people are people and have different things going on and how it may affect them, some type of appealable process to also be in place. That way, we don't have a hard and fast rule. We we need a hard and fast rule to some degree, but there also, I think, needs to be case-by-case evaluation for cases where it's very difficult or impossible to make a one-size-fits-all rule. Does that make sense?
And Larry, there always is that. Unless we have to exclude something,
okay,
there's always the ability, even if we say you only are, this is only in the, medical visit medication category. If someone wants to make a really good case why a procedure is needed, they could bring it to a medical director and, plead that case.
So you could say that the bar is there must be a functional limitation. We don't care. Not that we don't care, but social function isn't enough to require coverage. If you did that, there would be an exception process. I suspect exceptions would be fairly rare, but they probably would happen occasionally, medical directors.
And children get an extra level of review because of EPSDT.
You could also say social function if it reaches so many points on such and such a validated index, and we could bring that back for you to look at.
I feel very comfortable with what you just said. That sounds fine to me.
With the index or with the only function option?
With the idea, the appealable process.
Okay, so only function, but then an appealable process.
That's correct. Yeah.
Yes, I would not be in favor of trying to bring a social function construct to this conversation. Because it is going to happen on the individual level, which is where it ought to be. So
can we make a motion for that?
Mark's got hold on 1 second, Larry. Just on the current state, exactly what Ariel had mentioned is functional. It may be denied on a prior auth, but on the appeal, the provider may go into more detail regarding the comorbid conditions. For example, if there's a letter from a behavioral health provider that says this really provokes this patient's anxiety or social challenges, those are taken into consideration in the current state that we currently have.
Great.
And we don't expect that to change. And Larry, there's no need to make a motion. So I have highlighted a whole series of different things that I'm going to look into further, and I'm going to probably I think how you may see this in the future is I may break more of this out into individuals. So you'll probably see sort of a pretty standard, not a whole lot of question, and then all the like skin cysts and scars and things like that will probably be broken out into one or two additional topics. Um, and yeah, and are you all comfortable? So one of the questions that I've had and that kind of in my mind is are how comfortable is everyone with a lot of lumping? Do we want to keep like so I was sort of thinking of putting like most things that need derm procedures in one bucket. Do we still want to keep them a little bit more separate so you can have a little bit more fine distinction of what pairs with what? Anyway, Kat, I see your hand up.
Yeah, I think that would be helpful, and just knowing like which which proposed coverage guideline is going to be related to which new coverage. So I think a little bit more clarity would be helpful. I have a separate but unrelated question. I'm a little confused by the WIGS guideline, or is it the coverage
Oh,
guideline?
I've already realized that when I first wrote this, then we've had further internal discussions. So wigs are only going to be available for chemotherapy. Or radiation, which actually is going to take it out of the dermatology conditions. I just flagged that. It's going to just be on a complications group.
So will this second paragraph that seems to directly conflict the first paragraph go away?
The second paragraph is it's there currently. Radiodermatitis, drug-induced androgenic alopecia, and other specified non-scarring hearing loss. I think those are all currently on a complications line.
It says the only medically necessary treatment is a wig, but then the line above says only medically necessary for that. So it's just like
oh, I see. Yeah, I think I tried to fix, it's only included on this line. But yes, acute radiodermatitis has other treatments. Thank you for calling that out.
Okay.
That's all you got. It's a wig.
Yeah. I'm just gonna write myself some notes. Second paragraph needs rewording.
I was like, and then it's not medical. I was just very confused. So I was like, we'll fix it. It's good.
Okay, I will work on that. Thank you for calling that out. And then I see Mark's hand and then Mimi's hand. Mark, you're muted.
Right, because Zoom does not automatically put your hand down.
Oh, okay. Mimi?
When you were kind of talking about lumping things together, Ariel, I think, which it does make sense to me. I think just as long as there's specificity in the pairing, very specific therapies, well, I think that's where it is going to be important that it, again, is laser treatment approved for such and such. So you don't have a whole big long list of therapeutics. All of these can be used for a whole big long list, and like that could be mix and match. I think that part has to be very specific, which I think it will be, but I just want to confirm that.
Okay. Yeah, and it's been something I've been struggling with, how much lumping versus how much more specificity, since we're not going to be prioritizing. And it sounds like this might be too much lumping. I will look and make sure that all the different procedures have specific indications.
Just because some of the, I'm sorry, go ahead, Linnea.
Well, I was just going to say that this is where it gets really dicey, is people want that level of specificity because they want the clarity. And so the guidance, what guidance we provide, we have been providing guidance for many, many people, probably nationwide in some of the ways that we approach things. So I think there's going to be a fine line between what makes sense. But I do think, to Mimi's point, like if there's a certain group that fit together and have similar treatments, then I think that makes sense. But if they are disparate, if there's too many places to drive a truck through, then we're going to have more credibility issues of our work.
Yeah, and I'm even looking at this like UV light would be available. So yeah, I think we need to break things back out. The other question that I've been kind of struggling with is it, whether things would be better where we have like when is laser therapy, this every laser therapy is the only procedure in a group, and then it's all the diagnoses, and then those diagnoses might be in multiple groups, or whether we kind of look at acne and have all of its treatments. So two different
So,
ways that we could
so
group things.
dividing it by treatment options versus dividing it by diagnosis. Is that
Yeah.
what you're
Yeah.
talking about? Yeah.
One way you'd have treatments in multiple buckets, the other way you'd have diagnoses in multiple buckets. I don't think either way is wrong, but or we could continue to do kind of what we're doing now and have, well, I guess what we're doing now, we really kind of mix and match. We have diagnoses and treatments in different buckets. Okay. But I am hearing you all that this was too much lumping, and I will pull things back apart so that like acne surgery will only pair with acne, and we will look at what laser therapy and UV light therapy and stuff actually should be treating and make sure those are separated out. Okay. Anything else in this document that you all have a question about, or you want me to look into, or you want me to talk to our experts about?
Just a comment. I think that if we, since ultimately what we are dealing with is money, if we look at treatments, because different treatments cost different amounts of money. I think that not that that's the only way to look at it, but I think that that is an important way to look at it because we were wanting the most coverage for the most people.
Correct. And the default rule is the treatment needs to be the least costly alternative. And
Right.
so if there's a $500 treatment and a $100 treatment, there needs to be a reason before you can get the $500 treatment. And that's even if we don't have a policy, CCOs can enforce that. But sometimes we do specify things for that reason.
Yeah. And that
that's
happens all the time.
Yeah.
I want this medication. Well, it's much more expensive. Did you try the other one?
Right.
Did you have
But
side effects? Do you have allergies? Do you?
Right. That's where effectiveness and outcomes come into play and avoidance of adverse effects and side effects. Yeah.
Linnea?
I was just going to say, I think the knowledge of the cost is important, but I don't know that we want to use that as
Yeah.
the framework for what we discuss, because really it should be, again, back to medical necessity. And I think there's an economy to that, what we know to be proven for the resource to it. But I don't think that we as a part of the HERC are going to use that as a part of our decision making. And so I'm cautious
Yeah.
about it.
I wasn't suggesting putting a dollar amount there.
No. Traditionally, we have used sort of cost effectiveness. Sometimes,
Yeah.
Something is much more cost effective than another thing.
Yeah.
But what I'm hearing from you all is that you want the more specific, the way that things are kind of parsed out now on the prioritized list. You like that specificity. Like this should be done for acne. This should be done for psoriasis, and I will unwind a little bit of my recommendations. So yeah, so like what I'm anticipating for this is that I will break out scars and keloids into a topic. I'm going to break out probably cysts and lipomas into a topic. And then I'm going to rework this whole thing for the things that I don't think are very controversial with looking at some of the things you've specifically talked about. So you'll probably see some of this in a different format when you see it again.
Yeah, Linnea, I'm thinking the best bang for the buck.
I understand cost effectiveness, and I
Yeah.
do appreciate coming back in taking the feedback and coming back in a format that I think will make it easier, because I think we're just kind of the first blush of this, and so hopefully this will help with some guidance. That's what this whole project's about.
Yep.
Great. This was exactly the kind of discussion that I wanted. So thank you all for all of your work. This was great. I know it's not terribly satisfying to not have sort of a decision, but I think you have really called out things that will make this a much better product when you see it again. Any other comments on this? And you are also welcome if you're walking the dog tonight or taking a shower tomorrow morning and you have a great thought and you want to email me and say, I just really thought about this one thing and you need to look at it. That's perfect. I'm more than happy to have late comments as well. Are you all okay to move on to the first sort of focused dermatology topic? I'm seeing Mimi nod. Is everyone else okay? Okay.
Yes.
So the next topic on our agenda is actinic keratoses. These are small lesions on the skin that are caused by
Page
sun damage.
141.
And in very rare cases, they can lead to skin cancer, such as basal cell and squamous cell. This has been a non-covered condition since I think the implementation of the prioritized list back 30 years ago, and has been a really high source of anxiety with CMS. Squamous cell have a risk of progression to skin cancer of about 1 per 1,000, so very, very, very rare. And the skin cancers they progress to are the more easily treatable. So the squamous cell and basal cell, which has been our thought in the past that these could be treated when they do become a skin cancer if they are that rare one that progresses. So knowing that this is going to be a high interest diagnosis for CMS, I went ahead and I did a evidence review. There was a randomized trial in 2019, it was published in 2019, where they were looking at different medications. So actinic keratoses can be treated in a couple ways. There can be topical medications put on. And typically, once you have an AK, you have a lot of them because you've typically had sunburns or a lot of sun exposure. So they'll put this over a whole area of the body, such as the whole face or the whole back. The other way is to do sort of spot treatment with cryotherapy or liquid nitrogen, sort of freeze the areas. This was looking at different types of these topical medications, and their outcome they were looking for was a reduction of 75% or more in the number of AKs. And they found good results with many of these medications, and 5-fluorouracil, which is probably one of the most used medication, appeared to be the most efficacious at 12 months. Looking at expert guidelines, the American Academy of Dermatology's 2022 guidelines recommend sunscreen. We would all be in favor of that. And then 5-fluorouracil or another medication called imipquimod with a strong recommendation, moderate level of evidence. They do find significant evidence that cryotherapy is effective therapy for lesion directed. So if you just want to do a specific lesion and not a general area. And they strongly recommend cryotherapy. Their level of evidence is good practice. And then they looked at photodynamic light therapy and thought that the quality of evidence was low. The European guideline, which was published in 2023, they feel that treatment should be done case by case. You can do curettage, shave, or excisional biopsies, cryotherapy, laser treatment, or medications. Most private payers are paying for cryotherapy and or the topical medications. And CMS did have a guideline where they went through it, but this guideline appears to have been sunsetted, and they don't have any specifics about treatments. The experts looked at this summary with staff, and the charge I had given them was what kind of a guideline would you write? And kind of the conversation we just had essentially is, where's the best So what would be the most effective therapy for Medicaid? If you had to design a Medicaid coverage, what would you design? What they recommended was covering um, the topical medications. They said that that's what they typically use. That many of these, when you have an AK, you have a whole area that needs to be treated. The medications are rather low cost and safe. Um, and they thought that that should be sort of the general. Everyone should get that considered to be covered. And they only thought you should treat cryotherapy for patients who are high risk of progression, which would be those who are immunocompromised, have a history of basal or squamous cell skin cancer, or when the AK is located in an area that would be hard to excise if it turned into skin cancer, which would be the lips, nose, ear, or eyelid. So that is what we are recommending as staff option 1, so that we would move AKs to the code group that includes sort of the precancerous skin lesions. There'd be a new guideline that would say topical medications are available and cryotherapy is limited to those high risk groups. The other alternative would be to just make actinic keratoses evaluation and medical management, which would only give them cryotherapy, or not, would only give you medications and not cryotherapy.
Ariel, can you explain more why there's this stratification between cryotherapy and medications?
What I understood, so all of the there's good evidence for the medications. They are strongly recommended by experts, and our experts that we consulted felt that that was essentially the standard of care. And cryotherapy, because it's can be quite costly, particularly if you have multiple charges for multiple different areas where there is cryotherapy, they thought would be best reserved for people who are high risk. Do you all agree with that? Do you think cryotherapy should be more widely available?
Yes, I think it should be.
Linnea?
I think there was also consideration of people cryotherapy being per lesion procedure. I think I remember that in the conversation that it could be you have a field of 25 of them and you have 25 cryotherapy charges for procedural work. So if they could be bundled, I think that then it becomes more comparable to what would be done with a topical solution that is self-applied. So I think that was a part of the consideration. I do think that if there, I don't know if it's just the lips, nose, ears, eyelids, there may be a couple other places on the body where cryo, could be considered, but I think that would be available on a case-by-case consideration, right? With that we're not saying it's excluded.
I guess that's where when I do this in clinic, there are codes that are like 1 to 14 or more than 14. So there are cryotherapy codes that include if there are multiple ones. I guess the other thing just to think about is probably in primary care, there is a lot of cryotherapy that happens and probably not a lot of the medications. And so this may mean that this would only be treated in a dermatology setting versus a more primary care setting.
Okay. So Kat, I take that you would advocate for no limitations on cryo, that this would end up just being in the code group 240 without a guideline.
I'm not advocating, I guess I still don't totally understand, are the medications actually more effective than cryo? And then I guess I think patients have 6 to 12 months of wait list right now for dermatology. But if this is not an effective treatment, it shouldn't be covered. But it seems like if there is, the guideline would make sense to me. If they believe that that's an effective guideline, I just would.
So the dermatology guidelines say cryotherapy is first line for solitary AKs, which is probably where the disconnect is happening between the dermatologist and the primary care. Probably a couple of AKs is something that a primary care doctor feels comfortable with, but a whole body full of them might need a higher level of care. Linnea?
That is historical, but I'm like Mark. Didn't put my hand down, but I think it depends upon the provider and what their standard of practice is. And I think what Kat's alluding to is the standard of practice has been cryo and not so much topical. I do think there's always the consideration for some people you can treat in the office, you did it. Even if you've been treated with cryo, you don't realize it actually takes a while for the lesion to slough off. So that is confusing to people. But are people going to fill the script, and are they going to do the self-application sufficiently enough to treat the condition is often one of those other considerations. Does it really work in practice? So I don't know, Kat, if I'm over speaking for primary care. I've seen that.
So what I'm hearing from this discussion is that you all are comfortable moving AK into sort of the premalignant dermatologic lesion bucket, but you're not comfortable limiting cryotherapy. So we would just limit, we wouldn't have a guideline. We would just put them in there without a guideline. Does anyone want to argue against that?
I would.
Okay.
I think just that I would like to, and I'm sorry because I'm not doing an in-depth one, but if it's true that, one, we got to remember so few of these, like a tiny, tiny percentage will go to skin cancer. So, one might argue, okay, so, if there is not a rationale for the treatment, and if the medical treatment is actually better, if what you're really trying to do is prevent that endpoint of cancer, then it seems like these guidelines make more sense to actually have the guideline note. Because if people are sort of randomly taking off a AK here and there, well, maybe that doesn't actually need to happen.
So to your point, okay, from what I'm seeing, imiquimod seems to actually work better than liquid nitrogen. However, there's a couple of other considerations I'm thinking of. One is putting on 5-FU or imiquimod requires good patient adherence and follow-up. That's one. We know that patients are not always adherent to a treatment regimen, especially one that they may have to do for a period of time. The second thing is that although it is a small number, there can be progression to squamous cell carcinoma, and that is, I think, an important consideration. And it's not. I would not characterize the number as tiny. The third thing is that it's really difficult for patients to get into derm. And so if they're showing up in the office and a clinician sees something that they are concerned about, or a patient comes in with that, I think it's important to strike while the iron is hot.
So, this probably reflects my primary care bias, but we do cryotherapy all the time, and I just looked this up real quick. There's a systematic review and network meta-analysis in JAMA Dermatology from a few years ago suggesting, all these therapies, including cryotherapy, were effective over the long term for actinic keratoses. I would think that we want to maximize options for treatment in the primary care setting where possible. This is not a condition that you need to see a dermatologist for necessarily. It's a limited resource. It's, a lot of these patients are kind of like easily managed. I think it's a relatively low cost thing, but
can I apologize, Devin, carry on. I didn't mean to interrupt.
No. And also, it gives patient choice. I mean, there's side effects from 5-FU. You apply it broadly. You look like you have a sunburn and so on and so forth. But
I'm just going to comment on the low cost. I think is relative for an individual for one lesion. Yes, it could be low cost, but for a population of 500,000 who may get many of these done multiple times a year, it could be a very high cost for the population. So I would be, I would just be cautious on the cost of the cost, because individually, yes, population, probably not.
Is it
fair enough.
possible?
I think I was thinking in comparison to having to see a specialist and
Okay.
Is it possible for staff to get any type of coding data and to Mark's point, to actually see how much and how often and how much how often this is done and how much it costs?
Yeah, we actually have some data. You can go on with the discussion. I'll pull it up.
Yeah, I
Great.
mean, we
Thank
don't
you.
have a lot
Yeah.
of OHP specific cost data because this isn't covered, but we do have private payer, the all
Cool.
payer, all claims database.
Great.
And Ariel, quick question. I know that this has been a contentious topic, but what was the rationale for not covering it in the first place? Because that's the
But
system
it's
we've all
generally considered a cosmetic thing, that the chance of it becoming cancer is so low, and if it does become cancer, those cancers are very readily treated. So the cost benefit, sort of how much cost to prevent one skin cancer and how much cost to prevent, I mean, there's almost no death from basal and squamous cells, so it would be more one skin cancer surgery or um yeah. So that's where the Health Services Commission and its successor, the HERC, have kind of been standing on why we don't cover AKs. And I think this conversation is sort of encapsulates what CMS has been pushing back on, that there is a cancer risk, there should be some treatments, et cetera, et cetera. So I would have one thought. It doesn't sound like that it sounds like there's different opinions in this group. I could bring forward a proposal from this group that would have two options for HERC. One would be cover with a guideline that would limit cryotherapy. The other would be no limits on cryotherapy, and then let them have a fuller discussion, encapsulating all the things that you brought up. Would that be something that you all would be okay with?
Yes.
Sure.
As would I.
Yes, because it sounds like CMS wants us to cover this, so that's a mandate, and we got to figure out how to cover it, correct?
No, I
Strictly
wouldn't say that.
I wouldn't say that. The minimum that we would do is we would have to cover the condition for an office visit and medications, because that's the sort of minimum of anybody. So, and that would be something, I mean, we could argue with CMS that we are covering it. You could get the topical medications, and I don't know if that would, they might be fine with that. They might have concerns about not covering cryotherapy. I haven't, I don't know what CMS is thinking these days.
Okay. So there.
Yeah. So strictly from a cancer point of view, basal cell carcinomas don't metastasize, but we still treat them, and we spend a lot of money to treat them with
They become
surgery.
locally quite destructive.
They absolutely, I agree, but from a cancer standpoint, it's so I'm
having seen a person who had I don't know if it was, I can't remember if it was squamous or basal cell, that had not been treated and had basically eaten away a whole huge section of their face. They can become very serious,
Oh, yes.
but not probably metastatic squamous cell. I think there are case reports of it being metastatic.
I'm not clear that I heard anyone advocating for the third option that you're putting forth. So I guess I'm wondering
So I guess I've sort of changed from based on your discussion, I was going to modify what you're seeing, and it would be option one, which includes the guideline, and then option two would actually just be cover without, and just put it into the bucket that would have cryotherapy without a guideline with no limits. That doesn't look satisfying to you.
Yeah, I'm not clear anyone was necessarily arguing for that.
I heard Devin and Larry and at least arguing that there should be coverage in primary care with more broadly.
Yeah.
Yeah, I mean, maybe I'm confused as to what we're discussing. I guess I'm surprised that we don't cover cryotherapy in primary care for actinic keratoses. And again, that just probably reflects my own practice and what we do. But so I don't. But I thought that's what you were saying too, Kat. But now maybe I'm confused.
I think option two says no cryotherapy is covered by anybody anywhere. And so the option two seems overly restrictive because it seems like cryotherapy is a very
right. So option two we can take off the table.
Right.
Okay. Yeah. So that doesn't feel right.
Right. So then there would be the option one, and then a second option would be we'll put it into the dermatologic premalignant lesions with no guideline, which would pair with cryotherapy, and there would be no guideline to indicate
no restriction. Is that right?
Yeah. Or at least not unless you all wanted to just I guess.
I mean, is how expensive is 5FU?
Not very.
It's not very expensive now. Okay.
How expensive is liquid nitrogen?
Oh, cryotherapy is shockingly expensive if you've ever gotten a doctor's bill for it.
Oh, I'm sorry. Okay. I'm sorry. I was asking about.
Well, there's a difference between the bill that you get and what
how much my clinic pays for its its vat of liquid nitrogen versus how much we charge insurance for using it.
Yes. Yes.
I mean, how much does Medicaid have to pay for it, basically? And maybe this is ignorance about the individual cost.
It's like the non-facility rate is $93 for 11,400. Goes up from there with more complexity.
So that raises the question of bundling again, and I yeah.
And we can't require bundling. That's something
right. Yeah.
PCOs would have to negotiate.
Yeah, and I think the issue with cryotherapy in the past has been one individual treatment of one person, maybe $100, but they might need a treatment every 2 months for a year, and then there's 100,000 people on the Oregon Health Plan with an AK right now.
Right. That's why we need the coding data.
Yeah, and I looked at the data I have, and unfortunately, I can't give a good answer that's contextualized. So I don't want to give something that's going to mislead you. But that's something we could bring into the HERC discussion. We could work with our actuaries on that.
Okay,
yeah,
that'd be great.
So
yeah.
Liz has kind of drafted up. It would look prettier than this, and we will summarize this whole discussion. If this is what you guys kind of want, we could have option one being put it into the precancerous bucket and let we would have a guideline, so cryotherapy would be limited. Option 2 would be it would go into the precancerous bucket and there's no guideline, so there's no utilization control in cryotherapy.
The guideline seems reasonable.
I was shocked the dermatologist came up with the guideline.
Yeah. And I think HERC doesn't have to adhere to either recommendation we make.
Exactly.
Right.
Is there some type of middle ground here that would, because I think patients should have access to care with for cryotherapy. I guess it can't be addressed here because, and the only solution I see is the bundling.
I think option 1 would be the middle ground. It would be limited cases that would be eligible.
And I appreciate hearing that came from the derm folks. So, there already is some expertise that lent itself to the development of that note. So I agree, Ariel, sending it to HERC with 1 and then the modified 2, which is wide open door. And then HERC can look at those 2 options. And or just with the other opportunity is to send it with just the first option. I think never allowing cryo is probably, I'm not hearing anybody saying it should never be available.
I think I've heard strongly that the old option 2 is not acceptable to anyone.
So no option 2 the way it's written. Do we have an alternative option 2, or do we want to just recommend to go ahead with the guideline note that's there, and know that HERC will look at it and decide whether to go down that road or to change that up? I don't think you have to. So my opinion is you don't have to write an option 2 that says no limitations, because that's always a possibility.
And I will summarize this whole discussion and note that some people, that there was some thought about not including the guideline, and they can discuss whether that would have been a better option, even if we don't make it an option.
Okay.
Option 1.
Are folks okay with where we got in this discussion?
We have a vote on option 1.
Actually, I'm a little confused. So are we going to just bring option 1 forward and then let the HERC discuss the alternatives?
That's what I was suggesting.
Okay.
I agree with that.
Okay. And so where do we go from here?
So you would have to vote to approve staff option 1.
I make a motion to approve staff option 1.
Do we have a second?
I will second that.
Okay. Jessica, can you take us through a roll call vote?
Yes, I can. Mimi McDonald.
Approve.
Mark Buckles.
Approve.
Deb Espacente.
Approve.
Devin Consagara.
Approve.
Abigail Khan is absent. Larry Lyon.
Approve.
Kat Livingston.
Approve.
Leslie Sutton, are you here? I'm going to take that as a no. And Linnea Lindsay.
Approve.
Motion passes.
Great. So our next topic is probably equally I don't know if controversial is the right word, but has been of concern for many years, and this is viral warts. So viral warts are typically caused by the human
Page
HPV
146.
virus. They're
Thank you.
very, very, very common. We currently only cover them if they're in the anogenital region. And That's because in the anogenital region they can they can drive cancers in that area. Warts on the outside of the anogenital region don't lead to cancer. They can cause pain or discomfort. If they're on the bottom of the foot, they're called plantar warts. If there are other places in the body, we just call them warts. Frequently, they will self-resolve. They don't need treatment. There are lots of over-the-counter topical, basically irritants that can kind of help get them removed. And in the office in primary care, we use cryotherapy, which can help get rid of the wart, but may need to be done several times before a wart is completely removed. So essentially, these were prioritized on a very low line in 1996, and the only other discussion I could find was in 2012 when anogenital warts were moved to a covered line, which is where they are now. So the non-anogenital viral warts have not been discussed since 1996. So anogenital warts are on current line 384. Cutaneous warts, there's a clinical guideline that was published in 2022. They looked at like 1,250 studies. And there are all kinds of things you can do. You can do local injections, cryotherapy. You can do thermotherapy, which is heating instead of cooling. You can do lasers. You can do photodynamic therapy. There's all kinds of things that you can do. Injections of bleomycin, that just sounds really painful. You can use laser therapy. And other payers are essentially paying for almost all treatments. MODA does have some limitations, but they're pretty broad: bleeding, itching, pain, change in appearance, enlargement, etc.
I don't see duct tape as a treatment.
That would be considered over the counter,
Okay.
but has evidence of effectiveness.
Yes, it does.
So the dermatology experts recommended treatment of symptomatic warts. Again, this is the pain or function that I think we had a discussion about a little bit earlier, or causing distress because they're on publicly exposed places such as hands or face. So staff are recommending, again, a couple options. We could add plantar and other viral warts to the same line that the anogenital warts are on and just call it viral warts. And then the new guideline would say that it needed to be in a place that's subject to recurrent physical trauma or and there's documentation that such trauma has in fact occurred, or it's inflamed, or it's limiting physical function. For example, interfering with ability to bend a finger, use a pencil, causing eye issues, etc. And then the second option would basically just put them into medical management. So it would allow the non-PA'd medication, the over-the-counter, they use a whole variety of different substances on them. Thoughts here?
I'm sorry, go back to that treatment option, Ariel. Is that treatment would be over the counter? Is that?
So the guideline, oh, that's actually a good point. So the treatment with cryotherapy so no matter what we do, warts will be on a covered line that will be available for office visits and medications. So the decision really is, do we want to do cryotherapy? And Liz, if you want to put in the guideline, it says treatment of non-anogenital warts with cryotherapy is only medically necessary, because other treatments would be available to somebody without any of these. And the limitations would be, sort of they get physical trauma because of their location, they're inflamed, or they impair function of a hand or eye or orifice.
And I just want to understand from the process too, though, but the other option would be a not medically necessary or excluded list. Is that correct?
Yes. We could make them excluded, which would exclude any treatment at all. We could make them not medically necessary, which would allow treatment with an exception, or we could put them in the medical management group, which would allow an office visit, a specialist visit, and medication
Wait,
treatments.
the procedure, the cryotherapy would be the same procedure as for the AKs, right? It would
Yes.
be the diagnosis. We could put it in a conditions not covered group. But then you'd still want an office visit, right? Because the patient might know it's not something serious. So I think you'd want it in the evaluation and management group, right? You just want to not pair it with the cryotherapy.
If it's an evaluation and management, then medications would be available. I guess that would be the only thing. If we made it conditions not requiring treatment or whatever we're going to call that group, you would have to argue your case to get medications.
Or offices. Yeah.
Well, so for a
Everyone
diagnostic
gets an office
purposes, you get
visit,
an office visit to a specialist is covered.
Right. So you can see the specialist. That's current state.
Yeah,
Yes.
I don't think under drug rebate law we can control use of medications. It's about the FDA indications. But by using it, putting the diagnosis a different place, I don't think we can use that to exclude. There has to be a pathway to coverage for those medications.
Yeah, and this is an extremely common condition, and primary care doctors see it all the time. So, Mimi?
Nitrogen.
That said, I don't know if compound W would be a rebatable drug because it's over the counter. That's the other question, right?
Yeah.
Duct tape certainly is not.
I'm wondering if it might be possible to add on, well, if you're going to have a sort of a guideline note with cryotherapy, another potential way you could certainly have all of those, or failure of standard medical management or something like that in a way. And it could be, at first I was thinking with over-the-counter treatment, but that's not necessarily appropriate because if there are things that, primary care providers can, people can prescribe or have people use.
I guess the question would be, would you want that to be like a fourth criteria, or would you want it to be no matter what so sort of up at the top?
Right.
Treatment of cryotherapy requires you to fail standard therapy and have one of the following?
Right.
Or do you want
that one I'm going to defer to my primary care friends about what they think. If I do think that having failure of standard therapy is appropriate. And I don't know if they think that the remaining ones, it's too exclusionary, although I think, again, impedes use of finger or impairing physical function again is good to have there. It's still pretty broad.
And I would also agree with the medical therapy. I mean, up to date has first line therapy of salicylic acid. There's no PA required. You can get that easily.
Yeah.
And I'll be honest, the cryotherapy, I still have traumatic memories of a kid and getting a wart burned off. I mean, that stuff hurts.
Yeah, I mean, I think standard practice especially for kids is that it really when it's like they can't hold a pencil because it's like right here on their finger,
right.
Or and that would be covered with this.
Yeah, I mean, folks, I'm not sure how often it's used in primary care currently, but back in the day, we used to use that all the time, and it hurts. I'm sorry, that's a little post.
Yeah, I mean, no, there's
I think it can, but it's also can sometimes be a more time effective treatment in the sense that if you're lucky you'll knock it out with one treatment. But
are you talking about liquid nitrogen or
No.
Yeah, I still have a scar on the palm of my right hand from my doctor when I was a kid burning a wart off with trichloroacetic acid.
Right, right. Yeah, I wonder, I mean, this is probably not realistic, but it seems to me like the liquid nitrogen itself shouldn't be that expensive. But yeah, if they're charging $100 a pop to do something that takes 10 seconds to do, that's a lot. And I
Devin,
guess we don't really have any power over this, but it would seem to make more sense to reimburse for the cost of the liquid nitrogen tub uh, than it would to pay on a per
next,
procedure basis for this.
you actually can get liquid nitrogen over the counter at the
Oh,
drugstore. They have like little
really?
Yeah,
applicators for
yeah,
warts.
I've seen that. I mean, I don't think you get quite the same dose or the intensity that you would, but
Yeah.
I don't know. Do we have any kind of influence over how this stuff is covered?
No, I think that the
Uh,
charge is really for the professional judgment and application, not really for the liquid nitrogen.
And when I use liquid
The
nitrogen on
RVUs are
a,
set by the AMA. It's not something we can.
Yeah, I had a partner for years who um, she had everything ratcheted to wart equivalents. So an IUD placement was like 5 wart equivalents or whatever. Like it was for Ambujoly cat. You could,
now, just for the sake of accuracy, using liquid nitrogen on a wart does in fact take more than 10 seconds.
okay, so what
Okay.
I'm hearing is pretty much consensus for option 1 with a couple modifications to the guideline. And the modifications, if I can just kind of read you my notes. Treatment of non-anogenital warts with cryotherapy is only medically necessary when I have to words with those. I said failure of standard medical management and at least one of the following is present. So when they're, we usually don't like the word failure because it's just non-response to or something. So we'll wordsmith it, but that's essentially the idea that I'm hearing. Are people okay with that?
I have a question about that. So let's say somebody comes in and the doctor says, oh yeah, they want treatment for a wart. Is it sufficient to just ask the patient, have you tried treating this with some over-the-counter or standard medical treatment? And if they say yes, then to go ahead and use liquid nitrogen?
I think if the provider um, documents that the patient has tried
Okay,
over the counter X, Y, and Z.
okay.
Yeah,
And I think most patients probably do before
yeah.
they come into the office, but
Yeah.
Hmm.
I have an additional question, and it goes back to what we were talking about before. What say someone's got a big wart on their face? Okay, so it doesn't have a particular, it's there's no recurrent physical trauma. Okay, let's say it's not inflamed. It doesn't impair physical function. Okay, not painful, but how would that be covered, or could it be covered?
that
Or
would
is
be
this
covered through exception. And there would have
okay?
to be justification, probably a
Okay,
photograph or something forwarded to the plan.
okay, okay.
Oh, it,
And that would be part of this option 1. Is that correct?
there's always that by
Yeah.
exception unless we exclude it. So I appreciate
Okay.
Mark.
Yeah. Or you could add a 4th criteria that it's on the face. I mean,
Yeah.
Okay.
Mark, did you get spoken over? I was trying to look at that.
No, I do like the failure of medical therapy is always relative. We generally look at their filled meds because most folks will uh, somehow have some documentation of a failure of meds because most of the time it fails due to non-compliance for not using it long enough or whatnot. And so it's also somewhat subjective, but we definitely have approved cryotherapy for failure over-the-counter treatments. But boy, this is a huge bucket of people. Huge. Massive.
Yeah.
So we're looking at option one in
Yeah,
that what
with a couple modifications. So you'll see on your screen it says with cryotherapy, and then there'll also be some wording in there about non-response to standard medical therapy.
Mhm.
If that is that, I'm not hearing, I think we're hearing consensus on that. Do we want to vote on that?
I mean,
On option one, adding this coverage versus
Yeah,
leaving it as it was, which was to have just the exception for the anogenital warts.
well, we don't have that. We can't do current coverage. We would have to put it into evaluation and medical management, which would allow medications. That would be the other option. So no cryotherapy versus cryotherapy with a guideline.
Sorry, that's what I meant with the cryotherapy. Yeah. Yeah.
I mean, the as presented on the screen with the additional criteria that, I'm sorry, what was it, Ariel, at the beginning?
So treatment with cryotherapy of non-anogenital warts is only medically necessary when there's non-response to standard medical therapy and at least one of the following is present.
I have a question about this because I see a potential trap for both doctors and patients. What if the patient has tried standard medical therapy, even if it's over the counter?
Do you want to say, yeah, actually that's a good point, Liz. Do you want to do conservative therapy or standard medical therapy? Does anyone care? And then I'm sorry, Larry, we'll get back to you.
The conservative therapy would include the duct tape, right?
Yes.
And is it non-response or is it insufficient response?
Insufficient response.
Yes. Yeah, that sounds right. Okay.
You know, my feeling in this is actually different than the actinic keratosis one, because of the lack of progression to malignancy, and given the cost things that you all are bringing up, because these patients would still have access to the medications like imiquimod or whatever, for wart therapy, for that are non-responsive to, you know, over-the-counter things or whatever. So I wonder if there needs to be any recommendation for cryotherapy.
So you would be more along the lines of what's option 2, which is just evaluation and medical management, which would allow the office visit, the prescription for whatever substance, and no cryotherapy.
The only thing I'm not sure about that is that sufficient for plantar warts, which really can be problematic and require cryotherapy. Thanks.
Yeah, fair enough. And then make it hard to walk. But yeah, I mean, so that could be another option in terms of exception, which would be pretty specific and easier to implement and understand, would be the plantar wart option there. Otherwise, I'm not sure that you get much more out of doing cryotherapy than you would from doing the medication. And
can you add bottom of the foot to 1, or, you know, foot?
That's number 3, makes walking painful.
Yeah. But have you ever tried to do anything to the bottom of your foot that is painful on yourself?
No, but I've had a plantar wart taken out of the bottom of my foot by digging it out. That's what my PCP did when I was a kid. About 8. So we all have our story. And standards of care vary. So I think this guideline note, I think, is really moving in the right direction. But Devin, I want to make sure, do you feel like it's not conservative enough in its description? Do we need another bullet point, or?
Yeah, I mean, I would almost have what is.
I hear Devin advocating for option 2.
Okay.
Yes.
Yeah, I don't know what option 2 is, but there it is.
Yeah.
Yes, the does not allow cryotherapy
It would allow
because
it would allow medications. There would have to be
right,
a way to coverage, but that's the
exactly.
minimum we have. That option 2 is the bare minimum that we have to do for everything now.
Right. And that's partly why I'm saying it, because you'd have access to medication. But I agree with Mimi for the about the plantar wart exception to that, kind of non-resolving plantar wart.
So plantar wart is its own code. It's B07.0. We could
Ah,
actually just move plantar wart up to the anogenital wart group.
yeah. That might be a better way of doing it because these other exceptions are a little nebulous. Physical evidence of inflammation,
It seems pretty straightforward to me.
Okay, could you summarize that, Ariel, so we can move this along,
Yeah.
please?
So what I'm hearing Devin say is it would be modified option 2. Other plantar warts and viral warts unspecified would be put into evaluation of medical management, where they would have office visits and medications. But plantar wart, that specific code, would be put into the anogenital viral wart, and we probably would change the name to something like anogenital viral warts and plantar warts or something like that.
Okay.
I have a question. Are we setting up a trap for doctors and patients who, if they do not document the use of conservative or medical management and go on to use an additional treatment, let's say liquid nitrogen, would that care not be paid for? In other words, is the how something is
It's not paid for now. So what happens is my office before cryotherapy makes a patient sign a non-covered services form.
oh,
Um,
but
and we would only cover it if it's been prior authorized.
it just seems like a lot of administration for something so simple.
And the potential that Mark pointed out is that it could be many, many, many people over. I mean, that there's cost benefit. So I want to make sure we move along with because I realize we're after 4 o'clock now and don't have much time to get through the rest of this, although I know we have some time, but um, so Ariel, back to we would add planters warts to the non-anogenital viral warts, and then the rest so you'd move option 2 1A up, and so the only other thing is then other viral warts or viral wart unspecified would only be the cryotherapy would not be allowed for those. Is that
Right. So there the just generic viral warts would be an evaluation of medical management. Plantar wart would be an anogenital viral warts and plantar warts, or whatever. Well, we can name this.
Right. I think one of the main advantages of that, Devin, is that then removing a guideline note also then removes the potential for people wanting to require a PA, takes away a lot of the problem, and then people can get their plantar warts treated like they need
Yeah,
to.
but I could see a lot of problems with implementing a guideline and PAs for like, oh, your kid's got a wart on their finger. Here, let me freeze it. And
Well,
yeah,
I know that sounds horrible to have to do all that paperwork for that.
okay. So now
Um,
I'm hearing consensus around modified option 2, that plantar warts will be moved to anogenital viral warts and plantar warts will be the new name, and the other codes will just be evaluation of medical management. And there will be no guideline.
Again, I want to point out that although there is a significant cost consideration, we actually don't have the information that tells us what that cost is, and I'm concerned about that.
We can try to bring that for her.
Yeah.
Okay, great, thank you.
Yeah.
I would like to make a motion that we move this forward to HERC.
Without modified option 2?
With modified option 2, where plantar warts are moved into the anogenital wart sections, so they will be eligible for treatment, including cryotherapy, and other warts, or our warts are only E&M.
I second that.
Thank you. Jessica, take us to a roll call vote, please.
Wait, a quick question about that. Is this still appealable?
Yes.
Always.
It's always appealable unless it's excluded. Everything, always.
Okay. So, and the other viral warts and viral wart unspecified are not excluded. Is that correct?
They are not excluded. They are.
Okay.
Thank you. Okay, Jessica,
right.
take the vote.
Mimi McDonald.
That's a yes.
Yes,
Buckles. Was that you?
that's me. Yes.
Deb Espicente.
Yes. Yes.
Devin Kinsagara.
Yes.
Abigail Khan's not here. Larry Lyon.
Yes, with the caveat that I want more data.
Okay. Kat Livingston.
Approve.
Was that approved?
Yes.
Okay, sorry, I didn't hear. I didn't hear anything. Okay, and I don't think Leslie Sutton is here. Linnea Lindsay.
Approve.
Right, motion passes.
Thank you.
Great. So we have two topics that are teed up for HERC, and then the next one hopefully will be a little bit more straightforward. This is paniculectomy. That's the removal
Page
of
150.
Thank you.
excessive skin, usually in the abdomen, although it can be in the arms or the legs. Usually happens after someone has extreme weight loss. And with this, we currently don't cover this, and the reason we don't cover it is that the complication rate is extremely high. And we have discussed this at various points at the HERC, most recently in 2021. And there's very limited evidence that paniculectomy after significant weight loss improves quality of life or function, but extremely high rate of complications, including death. Major insurers are covering paniculectomy after weight loss with certain restrictions, but staff judgment was that the benefit does not outweigh the risks. And so the current recommendation is to essentially carry that forward. And we have a guideline currently, which we have a guideline for the non-funded treatment that we wrote very far back, that basically you have to have all sorts of different criteria. So what we could do is we could just kind of carry that guideline forward, and it would be the excessive and redundant skin would be on what we would call the paniculectomy line, as well as and then you would have this service according to the current guideline. Or the other option would be to say that paniculectomy is not medically necessary other than for gender-affirming surgery. And we would modify the current guideline to say that paniculectomy is not medically necessary due to high rate of complications and the risks of this service outweigh the benefits.
I have a question about that. Is the risk of complication for paniculectomy for after weight loss the same as the risk of complication for paniculectomy for gender-affirming surgery?
I don't know that we know that information at the moment, and I'm not sure that that is a part of the discussion we're going to have right now, unless we're looking at those two pieces separately. I think the question I have, Ariel, is this up to date when we talk about weight loss only as a result of bariatric surgery, and not talking about the application of GLP-1s where people are seeing great massive weight loss. And so if we're talking about stable weight for 6 months after treatment or stable weight. I just think if you're going to talk about surgery, we now need to talk about weight loss, and that is accomplished in other ways.
So the current guideline is agnostic to why you lost the weight, whether it was, traditional calorie limitation and exercise, whether it was medication or bariatric surgery. The only thing in here about bariatric surgery is that you need to be at least 18 months out from the surgery. And the criteria for being at a stable weight is that if you're continuing to lose weight, there's a possibility that you would need a repeat surgery, and this is a pretty high risk surgery. So essentially, you need to get down to where your weight is going to be stable, and then, deal with what sort of physical issues are going on.
So it's the repetition of a surgery that's a concern for risk, rather than you want somebody at a, regardless of how they got there.
So we don't care how they got there. And like I said, the bariatric surgery is only in there when because you need to be a certain amount of time after the surgery. I guess the stable weight would be for both directions. If you're continuing to lose weight, then whatever excessive tissue you have might become larger, and you might, if you had the surgery and you continued to lose weight, you might need a second surgery. It could also be if you're gaining weight again, you might have problems from the surgery because, you lose elasticity and ability to sort of, your shift if you're gaining weight.
Mm-hmm.
And I should highlight, we did receive 2 public comments about the importance of the service. One of them was referring to rashes, which would, appear to be covered by this one. It was hard to tell with the other one.
I think the second one was talking more about function.
Right.
I think there's kind of a philosophical consideration here, and I've only encountered this a couple of times in my own practice, but I do have some empathy for the patients that undertake massive efforts to lose a ton of weight and then are left with a disfiguring pannus, which causes both physical and psychological discomfort after having undertaken, kind of a massive change in their lifestyle and physical being. But it does seem like something that could potentially be dealt with on a case-by-case basis. So I guess I'm wondering if we can continue to do that, i.e., I had to kind of go through a lot to get my patient's paniculectomy approved through plastic surgery. And they worked with him a lot, and he eventually got it done and it went well. But it's kind of a one-off situation. So maybe this is an infrequent enough request that it can still be dealt with through the exception process, and we can gain more experience. I suspect this is one of those things that's very operator dependent as well, in terms of the balance of benefits and harms and all of that. I don't know. Those of you with more experience in the with OHP patients going through this specifically, what has this been like a large volume thing? Is it getting lots of requests for this, or?
We could find data if you want, at least the limited data that we can get from internally about like what the all claims database says about private coverage. I guess the concern in the past has been there is a very high rate of wound dehiscence, wound infections, deaths, various things. I'm glad your patient had good outcome. I mean, obviously,
Well, no,
there's a
I guess what I'm
range.
saying, but that's one of a lot of different patients,
Yeah.
which makes me kind of lean towards keeping this as an exception process, because the patient selection has to be really carefully considered. So I guess that would be advocating for keeping things the way they are. But perhaps monitoring kind of the exception process over the next few years to see
I
what
mean, one
happens.
thing that we could do if you guys want, so localized adiposity is excluded because that's where people get like a little bit of lipo because there's fat collections. But the excessive and redundant skin could be evaluation and medical management. And we could have the excisions all be just online, just for gender affirming treatment, and then available by exception.
Yes, I'm still pretty concerned that if the evidence suggests that the harms outweigh benefits, so we don't have proven benefit and we have risk of harm, including death. I guess I'm just still concerned about covering it.
I agree. And
Yeah,
and
I guess
to Devin's point, it also appears to be operator dependent to some degree, with plastic surgeons having the better outcomes.
I think this is pretty
yeah. So I
frequently
mean,
only done by plastic surgery.
yeah. I
Actually,
mean, so
actually,
I'm
it's done by
agreeing with the
plastics general,
non-coverage.
and plastics general and bariatric surgeons all do this.
Okay.
I mean, I guess I'm agreeing with the non-coverage, but
Okay.
partially that's because I do think there's isolated situations in which this could be a reasonable thing to do, but I suspect those situations are relatively few and far between and could be handled through the processes that we already have.
Okay.
And we have seen those that we've approved for if they have recurrent infections or some other comorbid condition. So we have looked at these, but I didn't realize the complication. It's over 50%. I mean, this is truly a challenging procedure.
Yeah, I mean, and it's not operator dependent. Some of it is just the nature of when you take out a large chunk of the fat and subcutaneous tissue and skin, just closing the wound and yeah.
Yeah, the potential for wound dehiscence is incredibly high just because of the strain on the incision line.
Yeah. So I'm kind of hearing people wanting option 2, but maybe no guideline. Just all the paniculectomy codes would either be not medically necessary, or the ones that would be gender affirming surgery would be still in that bucket. But no guideline saying that we don't cover it, so that there would be an exceptions allowed.
I'm comfortable with that.
Is someone ready to move that way of thinking?
Could I ask a question, you guys? Will there be, I don't know, I haven't thought of this before. So you know how currently there's sort of the E2 line, which is, I think it's either there's guideline E1 and E2 where things, okay. Is that still going to be an exclude? Okay. So I guess that would be I mean, I think Kat, that's perhaps what you were alluding to. Should this be on the excluded line?
Yeah, it can't really be because it needs to be there for gender affirming treatment.
Oh,
right.
Okay,
But
well,
that would be the guideline. Okay. If you want to page down a little bit, Liz, the second guideline proposal was essentially what would be excluded guideline 2.
Mm-hmm.
That's
And
on 152, option 2, page 152.
Yes.
Okay.
So keep it as not medically necessary, but not excluded. And then it is not medically necessary other than for gender affirmation surgery.
Okay, for
is that
conditions other than gender dysphoria?
I'm just concerned that the risk of this surgery is so great.
It's just because of the legal, Larry, in that context of gender affirming surgery,
We
so
are
many
bound
people.
by legislation. We
Okay.
have to cover.
Right. But there could be safety consideration as well in
Yeah.
that process. It's just done differently.
Yeah.
Okay. All right.
Yeah. So it would say paniculectomy for conditions other than gender dysphoria is not medically necessary due to high rate of complications. The risk of the service outweighs the benefits.
Gender affirmation surgery.
I'm sorry. Yep.
Just being careful there.
Thank you.
Yes.
Are we ready to make a motion?
I think we can call for that. Somebody ready?
I move for option 2
As modified?
as modified.
Okay. Is there a second?
Second.
Thanks, Devin. Jessica, would you please call a roll?
Mimi McDonald. Mimi?
I think we lost her.
Oh. Okay. Mark Buckles.
I agree. Approve.
Deb Espacente.
Approve.
Devin Kinsagara.
Yes.
Okay. Larry Lyon.
I approve.
Kat Livingston.
Approve.
And Leslie Sutton.
Mimi's trying to get back in.
Oh, Mimi's trying to get back in? Okay.
Yeah.
Okay. Should we wait to finalize
Yeah, let's give her a minute, let her vote.
Okay. Should I ask for Linnea's vote next? Oh, wait.
Let's just give her a second.
Okay.
Well, maybe we should go ahead. So we can
Yeah.
move on.
All right,
We have enough people to have it pass, correct? Without
Yeah, we have enough for quorum. So I will say aye, yes, agree, approve.
Okay.
And so I think it sounds like for those who are here,
Passes.
Yes.
And we'll list her as absent for the vote.
Yes.
All right. So that ends our first foray into dermatology. So the 3 subtopics that you made decisions on will come to HERC at the May meeting, which is May 15th. You're welcome to obviously attend that meeting or virtually or in person in Wilsonville. The general dermatology will be further worked on by staff and will be brought back to, I anticipate, the June EBGS meeting. So now we're going to move into ENT. We have about a half an hour left. Does anyone have any strong preferences about a ENT topic they really want to talk about today? Otherwise, we can kind of take them in the order that they were in your packet. Okay, so what's showing on the screen in front of you, because I broke ENT into
Page
multiple...
157.
Thank you.
I broke ENT into multiple subtopics, and so this is kind of an overall summary. And one of the differences in the ENT proposal is I really had to pull from covered and non-covered lines to make a coherent code grouping. And this is because we've kind of twisted ourselves into a pretzel over the years trying to put things on covered lines that so we could get certain things, and it ended up being very convoluted. So there's a little bit more blending than you were seeing. And then there'll be additional procedures being proposed for coverage. And so that's definitely something that we need to talk about. We currently have a guideline about septoplasty and a guideline about rhinoplasty, but many of the indications for these procedures are non-covered, and that's called out in the guidelines. So because we now have to cover these, we would need to consider whether we want to move forward with kind of fully operationalizing those guidelines and covering those services if they meet that criteria. And then there was a septal cartilage dislocation of the nose. Apparently, this happens a lot in newborns, and ENTs just fix it in the office. So, adding coverage for that. Salivary gland issues, we were hearing quite a bit of uh, requests from the specialists that this be covered for someone who is having like skin breakdowns or infections or things that they see this in certain neurologic conditions, etc. And then there's kind of minimal change to PE tubes and tympanostomy, salivary gland, the kind of chronic sinusitis type of things, vocal cords, tympanic membrane perforation. And then there's a whole bunch of just sort of generic ENT issues that we'll go through. So I guess we can just plunge in with the first topic, which is the PE tube, the tympanostomy and PE tubes. This, as I mentioned with that whole summary, is probably a minimal impact. What we would do
Page
is
166.
we currently cover the tubes that go through the eardrum to kind of allow pressure equalization between the inner and outer ear. We currently cover it for acute recurrent otitis media, but not for chronic otitis media. This would kind of combine them. It would allow coverage. We do currently cover chronic otitis media when it results in hearing loss, which is pretty much what the ENTs were telling me they use before they do PE tubes. So the only real difference would be the just generic diagnosis of chronic otitis media would have added coverage, which we don't think, based on expert input, would have much real life impact on what's being done. And then we would take the tympanostomy related procedure codes off the hearing loss lines, and make it more of pure treatments for hearing loss, like the different hearing aids and cochlear implants and things. This isn't technically a treatment for hearing loss per se. It's a treatment for hearing loss due to inner ear conditions. So these PE tubes are currently on many covered lines, as well as the chronic otitis media line, which has always infamously been the first non-covered line on the prioritized list. We do have a current guideline for acute otitis media, which would require that you have 3 or more well-documented and separate episodes in a certain period of time of acute otitis media. We also have chronic otitis media with effusion, has a guideline specifying that we pay for medications, we pay for PE tubes for people with craniofacial anomalies or with hearing loss, and we would pay for an adenoidectomy if you're getting a PE tube. So Dr. Peggy Kelly and Dr. Sarah Yang were kind enough to help me with this. Dr. Kelly is pediatric ENT and Dr. Yang is adult ENT. So the recommendation is to create a new code group called PE tubes, adenoidectomy, tympanostomy, or tympanoplasty, excuse me. All the office visit codes would be in there, or actually they may end up being in, never mind. They would have office visits, and then they would have a variety of procedures. And then essentially the current acute otitis media guideline would be modified to kind of fold in the chronic otitis media criteria. So we're kind of combining our 2 current guidelines into a single guideline that would, it would say you would get for acute otitis media, you have a couple different things. For chronic otitis media, you have to meet certain other criteria. And then this would now move a whole series of diagnoses into this new group, and it would remove some of these things from the hearing loss line and just leave them on a couple of the current covered code groups.
So this may seem like a lot of change, but we're expecting very little functional impact. I'm very curious if Kat and Mark agree with that, since they've probably been more intimately acquainted with this than any of the others. maybe not sure.
Yeah, that's what I was thinking.
I'm sorry, what were you thinking, Mark?
That it wouldn't be a huge impact. Can you scroll back up? There you go. Okay. Uh, yeah. And can you scroll down a little bit? Mhm.
I do think having one guideline note will be nice from
Yeah.
someone who's chased all over the prioritized list for this. And also it does make a lot of sense to have the procedure codes for PE tubes and adenoidectomy separated from the hearing loss coding groups, because really, although hearing loss is kind of it's something that is going to be treated for this, it's actually the other condition that more proximal condition is what you're treating. So
Yeah, and this guideline
nice clarity work.
is kind of folding two guidelines together right now.
Right. And that's what it looks familiar. And it's still not covered for adults with full ears or fluid in the ears that we see a fair amount of, correct?
It doesn't have an age limit. So if they met these criteria,
Because the other one did have an age limit, correct?
so chronic otitis media is covered for children up to and including age 7, and then children over 7 without high risk conditions, only if they have hearing loss. So I guess it would cover adults with craniofacial, the way I'm reading this.
Okay.
But
And that's how we currently interpret it.
okay.
Oh, could I ask you a question, Ariel? And it's probably somewhere written in the OARs, but when, and just it gets a little confusing with EPSTT, children over the age of 7, does that mean up until, where's the end on children? Is it 18 or is it 20?
One of the unanswerable questions.
I'm so sorry.
For EPSTT, it is the 21st birthday. I always remember it same as a drinking age.
Yeah. And that's
Right.
how
So
I think OHA has been interpreting things, is up to the 21st birthday as
But I just
child.
think maybe children between the ages of 7 and, whatever.
Over the age of 7
and under,
still children.
and under age 21.
Yeah, I know, sorry, but to add more verbiage, but it is, it gets a little sticky.
Yeah, and the question of 18 versus 21 is a perennial question.
Right. But anyway,
if we put in there,
we'll do the HA
so
way,
we could say, so up to and including age 7, the kids get a pass. 7 to age 21, and so over the age of 7 and under age 21, without high risk conditions, they have to have hearing loss for 3 to 6 months.
Right.
And that 7 is justifiable with EPSDT because there is a hearing and speech language developmental period that is thought to kind of be closing at age 7.
Where did the 3 months of hearing loss come from?
That has been our guideline for years. I believe it's because that's typically what an ENT will see somebody back at in a 3-month interval.
I'm just thinking in a kid, 3 months of hearing loss can be pretty significant.
Well, the natural history of chronic otitis media and effusions is that they will clear up in 3 months. So you would be putting a kid through unneeded anesthesia and procedure.
Okay.
So does this mean DA is new coverage of adults? Because in the old guideline, when I look at it, that's part of a sentence that is children up to and including age 7. So since
the way it children with language delay learning problems or significant hearing loss should have hearing tested. The current chronic otitis media says patients with specific high-risk conditions, along with hearing loss and chronic otitis media with effusion are intended to be covered. Oh, for children up to and including age 7. Okay.
So it looks like as written, this would newly cover 7 and up through adulthood. So if the intent was to keep it consistent, then it seems like that.
So children up to age 21 with specific higher risk conditions?
The children under the age of 21.
Is that an edit of DA?
Yes.
Okay.
Wait, but then DB, so is DB brand new? Because it looks like when I'm looking at the old one, the only way to get it covered currently is DA A plus B. Is that true?
So for coverage. Okay, so high kids up to age, including age 7 with high risk conditions are included on covered lines.
So who are you
Children with
trying to
chronic
exclude? You're
otitis
trying
who
to
are not
exclude.
at risk for hearing for language delay or developmental delay. Oh, okay. So you're right. If you read this, the children who do not have craniofacial anomalies and they don't have language delay or learning problems should just be followed until they actually show hearing loss.
You're right.
So yeah, I think we should strike B. So it'd be children under age 21 with craniofacial anomalies get a pass. If you're between 7 and, oh, I guess children under the age of 21 with high risk conditions.
Yeah, Liz, I think under A, you need to add children under the age of 21. DA, sorry.
Yeah, so I have D, chronic otitis media with hearing loss in one of the following clinical situations. A, children under age 21 with specific high risk conditions, or what will now be B, children under age 21 without high risk conditions who have documented hearing loss after 3 to 6 months of a waiting period.
That's current C.
Repeat that once more.
It's current letter C.
Right.
Except for instead of saying over age 7, it'll say under age 21. Or we could actually put that up in just in D. Chronic otitis media with hearing loss is covered for children under the age of 21. Or we can wordsmith this a little bit.
Yeah, we can wordsmith it before the HERC meeting, but I think we understand what you all want to do.
But the intent is to keep it the same. Is that what we're talking about this current?
Yeah, the intent is. So it would be high risk kids or kids who have hearing loss for a while.
Okay, yeah, DB just seems sort of like any kid under 7 with any amount of hearing loss.
Yeah, that probably wouldn't be good. Yeah, okay.
Okay, which seems like it's a change in current coverage.
Yeah, I didn't intend it to be a change, so it was probably me trying to simplify the guideline a little too much. So we still have our high risk conditions. They get procedures. And it's actually high risk conditions up to and including age 7. Do we want to just say under age 21 or do you want to do up to age 7?
Well, what puts us in compliance with EPG? I'll get it. Never mind. What puts us in compliance? Because I think that's the thing that may be tripping us up is EPSD, TSD guidelines are saying we need to cover almost anything for a child, right? That's with medical necessity. So is that why you perhaps put DB in there? because there is that exception around developmentally that they're not at risk, but you wouldn't.
How about I suggest this? Why don't you allow staff to take this back and work this over again? Because I don't like to do all this on the fly wordsmithing. Let me really go through the guideline and make sure that the intent is to transfer the current coverage into the new world. And I just need to make sure that the wording reflects that. And then we can bring it back to our next meeting and you guys can take another look at it. Does that sound like a plan? Kind of table it for now?
Makes
But I'm
sense.
hearing otherwise the general idea is fine. It's just the devil's in the detail. You want me to make sure that I get the wording right in the guideline. Linnea, you have your hand up.
Oh, that was not intentional.
No worries.
Zoom is just different. But yeah, I think that's exactly what I'm hearing the consensus, Ariel, to be in this situation. And I want to be mindful, it's 13 minutes to 5. So do you want to just take it back and not take a vote? Or do you want us to vote and then take it back with our consensus that we have enough faith that you're going to wordsmith it to what our intention is? What would folks prefer?
Take it back and think on it.
I would think I would prefer to have you all approve my wording just because this is a tricky
It is.
topic.
Okay. So we'll let you take it back and we'll leave that one. Do we want to try for one more today or not?
Mm.
The next one is septoplasty, rhinoplasty, and nasal polyps.
Oh,
No.
we better, we need more
That's
time
why
for
I scrolled to the next one and went, yeah, no.
Okay, yeah, and we really only have 10 minutes plus so I think this is a good point to stop. So for our June meeting, you'll see the general dermatology again, with a couple of new breakouts. You'll see the PE tubes and tympanostomy topic back with basically more of a consent agenda item with you all, just making sure the guideline looks good. And then all of the other ENT topics will come back. That'll probably be more than enough for our discussion in June.
Good.
And in the meantime, if anyone did get a chance to look through all the ENT topics and had notes or had any things already flagged and want to send them to me, I'm happy to look at them earlier.
So our next meeting is set aside for June 5th. Is that correct?
That is correct.
That is correct.
Okay.
2 to 5 p.m. And this group has not been taking us up on in person. Is that what you want to do, just to continue to have them online?
Yeah, it just makes the day a whole lot longer.
Yes, it does. Okay. We will
And
plan
again,
on that.
you're all welcome to the May 15th HERC meeting to discuss, in the afternoon to talk about the topics that we did approve and forward to them if you would like. And there's virtual and in-person options for that. And don't forget the retreat is a week from Friday.
Look forward to seeing many of you there.
Yeah.
Okay.
Any other business or any other things that people want to throw on the table before we adjourn? Mimi's like, no, that was enough.
I don't expect an answer to this, but any thoughts? I anticipate that we're going to be expecting a lot less financial support from the feds. Is that going to affect what we are doing?
So we'll have an update from our Health Policy and Analytics Director, Claire Pierce-Roble, and she is back from CMS. She's new to the agency from CMS. She will tell us what she can say. All of this is obviously very dynamic and sensitive and, in Congress. So I don't know how much she'll be able to share, but she'll be able to give you whatever we are able to say.
Great.
Next Friday
Yeah.
at the retreat.
Good.
Well, thank you, everybody. Great meeting. Appreciate all the good work, and we'll see you next time.
Right.
Meeting's
Bye-bye.
Thank you all.
Bye.